Hello everyone. Today we are going to talk about contraceptives. Contraceptives are basically methods to prevent pregnancy. These are basically, there are multiple types, but for this class purpose, let us take ourselves to hormonal contraceptives. These hormonal contraceptives can be either oral or parenteral. Fine. With respect to oral contraceptives, they are further divided into combined pills, mini pills, or progesterone-only pills, and then your postcoital pills or emergency pills. There is a newer addition to this, Centproman. With respect to parenteral, there are many. One such as injectables. Injectables primarily are given intramuscular, and then there are recent methods or recent advances which mainly includes progesterone, which is an intrauterine insert of your progesterone, as well as subcutaneous implants. With this background, let us talk about mechanism of action of these contraceptive pills. Consider this as our uterus. This is our fallopian tube, ovary, ovarian follicle, and ovum. On appropriate stimulus, ovum will be released into the peritoneal cavity. Your fallopian tube fimbriae help us to absorb this ovum and it enters into the fallopian tube. Usually, fertilization happens in the mid fallopian tube somewhere here. Sperm enters from here, and the entered sperm is motile. It starts swimming and it reaches mid fallopian tube, and somewhere fertilization happens here. After fertilization, it is more of a implant. After fertilization, more of an implantation happens here. For implantation to happen, you need appropriate endometrial bed. This is your normal physiology. So what happens is, contraceptives mainly anterior pituitary releases FSH and LH under the influence of gonadotropin releasing hormone, which is secreted from hypothalamus. This FSH and LH acts on ovary. This results in the release of either estrogen or progesterone. Estrogen has a direct feedback mechanism on FSH, whereas progesterone has a feedback mechanism on both LH as well as FSH. Both these hormones also have a long feedback mechanism on your GnRH. These are the two important physiological roles of a physiological thing. And now, what usually happens is, when we supplement hormones, that is your contraceptives, because of continuous presence of, this is your first mechanism of action, because of continuous presence of estrogen and progesterone, there will be inhibition of FSH and LH. Because of no FSH and LH mid-cycle surge, no ovulation happens. This will not be there, so no ovulation. Female bears and ovulatory cycles. This is our first mechanism. Second mechanism is your fallopian tube movements are very important. Fallopian tube movements are out of synchrony. Asynchronous fallopian tube movements will be there, so that movement of ovum will be restricted. Third one is cervical and vaginal environment will be hostile, mainly by changing the epithelium, hostile environment, so that my sperm cannot swim up. And finally, appropriate implantation bed, that is uterine endometrium will be out of phase endometrium, either hypoplastic or hyperplastic, it can be anything, but implantation will not happen. So these are the four methods by which your contraceptives act. Let us once revise again. First thing is obviously inhibition of FSH and LH. Second thing is improper fallopian tube movements. Third thing is vaginal and cervical hostile environments. Finally, inappropriate endometrial bed. These are the four important things. Now, here in the classification, we saw that oral pills are combined pills, mini pills or progesterone-only pills, postcoital pills. So, we will compare the mechanism of action of each. So, combined pills, that is estrogen plus progestin, and then progestin only pills, and then your emergency pills. Fine. All the four, 1, 2, 3, and 4. First one is inhibition of FSH and LH. This is prime mechanism and this is present. This is highly efficient in a combined oral contraceptive pills. As seen during the mechanism, estrogen has a major role in giving a feedback to FSH. In a progesterone-only pill, there is no estrogen. So, this step, though present, will not be that efficient. Even in an emergency pill, progestin forms a major role. So, this is not that important. It may happen, may not happen. We are not bothered also. But this does not form a major role. Clear? Now, let us talk about the second one. That is, what is the second one? Fallopian tube movements. These fallopian tube movements are out of phase with all. In the same way, cervical and vaginal hostile epithelium is most important action in these. Clear? Whereas this plays a role, but this is most important with respect to this. Implantation, out of phase endometrium is most important mode of action for your emergency contraceptive pills. Based on this, let us compare the efficacy or failure rate, anything. Estrogen is highest efficacious drug. It is efficient in 99.7% cases, whereas progesterone-only pill is good for 96%, whereas emergency pill is much more or less 93 to 96%. Clear? Now, this forms the mechanism of action as well as comparison between various efficacies. Now, let us talk about preparations. From here on, we will talk individually. First, combined oral contraceptive pills. Combined oral contraceptive pills are a combination of estrogen plus progestin. Estrogen and progestin, mainly estrogen is given in the form of ethinyl estradiol. Ethinyl estradiol and is given usually at a dose of 50 micrograms. And in an obese person, is usually given in a dose of 30 micrograms. In a dose of 30 micrograms, this is your standard dose. Whereas your ethinyl estradiol in a dose of 50 micrograms is preferred in obese people. In the same way, ethinyl estradiol in a dose of 20 micrograms or low dose estrogens are given in all those patients who have certain risks. Clear? Now, depending on the progesterone, we should always choose progesterones which have least androgenic action. For that reason, preferred progesterone is always desogestrel because it has least androgenic action. Government supply is either norgestrel or levonorgestrel. Ethinyl estradiol plus norgestrel is Mala N. Ethinyl estradiol plus desogestrel is Femilon. Clear? Now, how are these seen? Let us say this is our OC pill. There will be 7 tablets. 7. In the same way, 4 such rows will be present. Clear? Days will be written 1, 2, 3, 4, 5, 6, 7 along with the arrows. 1 to 21 days is estrogen plus progestin. 22 to 28 days, that is a period of 7 days, is iron. Usually the last one will be iron. During this time only, during the time when patient takes iron, usually because of no hormonal supplementation, patient ends up with withdrawal bleeding. For some patients, even during 1 to 21 days, there is always a chance of breakthrough bleeding. To overcome this breakthrough bleeding, what we have done is, we have introduced triphasic pill. Because physiologically, progesterone is not same throughout our menstrual cycle. So, what they have done is, ethinyl estradiol is standard, constant, 30 micrograms of ethinyl estradiol. But progesterone is slowly increased. Let us take this as graph. Ethinyl estradiol concentration is standard, but progesterone concentration is slowly increased. This is called as phasic pills. These phasic pills are given importance these days mainly because they mimic physiological thing. Physiologically, slowly increase will be there. Clear? Now, these triphasic pills are primarily preferred in females whose age is more than 35 years, as well as those who complain of breakthrough bleeding with your monophasic pills, breakthrough bleed, as well as there are risk factors associated. Clear? This is about our combined oral contraceptive pill preparation. And how are they and how do we use? Now, let us talk about progestin-only pill. This is also, I am talking only about preparations here. Progestin-only pill primarily contains only progestin in it. Usually, norgestrel is preferred and is given only in females who are more than 35 years of age. And if a patient is on progesterone only pill and if amenorrhea is present for more than 2 cycles, then UPT must be done because of high failure rates. Now let us talk about third one, that is our postcoital pill. Postcoital pill preparation. Postcoital pill is usually levonorgestrel either in a dose of 1.5 milligrams stat or 0.75 milligrams now, 12 hours gap, 0.75 milligrams. This is our first one. Second one, oral contraceptive. This is levonorgestrel, okay? Levonorgestrel. OC pills, 2 tablets now, 12 hours gap, again 2 tablets. Clear? This is other method. Now, with third one is mifepristone. Mifepristone is usually given at a dose of 600 milligrams stat and followed by misoprostol sometimes without any, it depends. Okay, and then fourth one is ulipristal. Ulipristal is given at a dose of 30 milligrams stat dose, both are stat doses. All these first three should be taken within 72 hours of unprotected exposure. Ulipristal can be taken from 120 hours of unprotected exposure. That's the only advantage. And there is one more contraceptive method which can be used as emergency, though it is not hormonal. It is your intrauterine device, mainly copper T. And when we insert copper T as a method of emergency, there is a very high chances of ectopic pregnancy. For this reason, we usually don't prefer IUD as a this thing. Now with this we have finished preparations. Now we will talk about what are the combinations. Preparations are finished. Yes. Now we will talk about precautions. From here we will talk only about our combined oral contraceptive pills. Clear? Precautions. First thing is missed pill. With respect to combined oral contraceptives, patient has to take 1 tablet every day in the night. Yes, let us say a patient due to n number of reasons did not take only 1 tablet. She has missed only 1 dose. We'll ask the patient to take 2 tablets the next day and continue. Clear? Second thing is, if the patient has forgotten 2 or more than 2 tablets, we'll ask the patient to follow other methods of contraception, other contraceptive methods, and we'll ask the patient to remove the tablets whatever they have forgotten and continue the rest. Because if she stops, usually patient ends up with withdrawal bleeding. That is one more issue. This is one of the most important thing. Second thing, if a female becomes pregnant when she is on any sort of hormonal contraceptive, we must advise medical termination of pregnancy. Clear? These are the most important precautions. Now, let us talk about side effects. Why are we more bothered about side effects is, see, I forgot one more important thing. I just told. Now, let us talk about side effects. These side effects are divided into mild, moderate and severe. We'll start with severe. These are something you have to remember. First C stands for cholestatic hepatitis. Then your serious issues like thromboembolism. Third one, your CNS issues like depression. OC pills does not cause depression. They stimulate the subclinical depression. They make it overly latent. Clear? And finally, fourth C is cancers. Mainly, this increases the risk of breast cancer as well as cervical cancer. All these are because of estrogen component. Clear? Now, let us talk about moderate side effects. See, moderate side effects are not that a big issue, but cosmetically they are very important. A stands for acne and hirsutism. B stands for breast discomfort. And C stands for cloasma. All these are cosmetically important. Clear? And then mild side effects. These are not at all significant. We'll just reassure the patient and allow the patient to continue the medication. Fine. They mainly include nausea, vomiting, weight gain, migraine precipitation, cycle disruption, your menstrual cycle disruption can be present in some, as well as your breast discomfort. These are the most important issues. Now, with this background, let us talk about contraindications. See, there are many absolute contraindications and relative contraindications is what we will read. Basically, all severe side effects come under absolute contraindication. Along with this, relative contraindications mainly include obesity, diabetes, hypertension. Clear? Now, what are the drug interactions? Most important drug interactions we have to remember are only two. One, when a patient is having tuberculosis and is prescribed rifampicin or any such drugs which are primarily enzyme inducers like your anti-epileptics. In those patients, they induce, these all are anti-epileptics, these all are primarily enzyme inducers. So they increase the metabolism of estrogen as well as progestin. So contraceptive failure may happen. Clear? Now, the other drug interaction what you have to remember is use of broad spectrum antibiotics, antimicrobial agents, primarily tetracyclines and chloramphenicol, will result in contraceptive failure, OC pills failure. Why? Because of they inhibit bacterial flora. So that enterohepatic cycle, which is important to maintain the T half of estrogen, will be disturbed. These are the important drug interactions. Now, we will talk about non-contraceptive uses of oral contraceptive pills. Here, oral contraceptives I am talking only about combined oral contraceptive pills. First one is PCOS. Then we are talking about breast tumors like fibroadenoma, benign breast diseases like your fibroadenoma, reduces the incidence of ectopic pregnancy, reduces the incidence of neoplasms like endometrium. Endometrial cancer incidence is reduced, as well as ovarian cancer incidence is reduced. Clear? Now, as well as it reduces the incidence of endometriosis, and they also reduce the incidence of osteoporosis. And also, we must be bothered about our premenstrual syndrome. These are the non-contraceptive uses of oral contraceptives. Clear? I think with this we have finished combined oral contraceptives as a whole. Clear? Now we will talk about something much more important. Indications for progestin-only pill. Progestin-only pill has higher failure rate and is preferred in only females who have 35 years of age, and all these issues, all these contraindications or side effects if they develop with OC pills. With respect to emergency pills, it is more of a social cause, so they are not used that regularly, and there is a lot of failure with them. I forgot to tell one most important rationale of combining estrogen with progestin in oral contraceptive pills. Obviously, all the mechanism of actions we have to write. That is, they give proper negative feedback of LH search so that ovulation is inhibited. This will be my first point. Second point will be your fallopian tube movements out of sync, and third one will be cervical and vaginal hostile environment. Fourth one will be out of phase endometrium. Then comes the most important, when estrogen is given alone. Let us see this. Estrogen is responsible for endometrial proliferation. Yes or no? So, when estrogen is given alone, there is unopposed endometrial proliferation resulting in increased endometrial cancer. When progesterone is given, the risk of endometrial cancer is gravely reduced. Clear? These are the reasons of combining estrogen and progestin. For an MBBS person, this is very, very important. Usually asked for 3 marks and 5 marks questions. I think with this we have finished our oral contraceptives. Yes? Let us go into the starting page where we have classified. We have finished oral contraceptives. With this background, let us talk about injectable contraceptives. See, there is nothing more to add here. With respect to injectable contraceptives, these are once preferred, but now I don't think anyone is doing this because there are a lot of issues with injectable contraceptives. One such thing is, animal data showed increased chances of CS. Animal data only. No human studies have supported it. And see, contraceptives are used for temporary reduction of your fertility. But these injectable contraceptives, and once your oral hormonal contraceptive pills are stopped, usually it takes around 2 to 3 weeks. That's it, 2 to 3 cycles for your fertility to regain. But with respect to injectable contraceptives, return of fertility. is a query. Sometimes it may take 6 months and sometimes the patient may be infertile forever. This is very poor. And then reduced bone mineral density is also seen in some. In the same way, menstrual irregularities, which are a very big issue, menstrual irregularities as well as menopause-like symptoms are also seen in some. So what are all the injectables we know? There are only two injections. One is depot medroxyprogesterone acetate. The other one is norethindrone enanthate. DMPA and NEE. Both have very long half-lives. Both are given intramuscular. DMPA has a T half of 3 weeks. NEE has a T half of 2 months. And both are not used these days very often. With this, we have finished the injectable contraceptives also. In the injectable contraceptives, we just mentioned certain recent advances, mainly progestasert and norplant. Yes, norplant and progestasert, basically they are used for, we'll talk about it also. Sorry. Now, progestasert is basically a intrauterine insert of progestin can be used up to 1 year but less efficacy. And then your norplant, it is the intrauterine insert. This is subcutaneously given and is useful. This is also progestin only, mainly levonorgestrel, and it is used for a period of 5 years. And recently we have one more transdermal patch, weekly ones. It contains both estrogen and progestin. I think with this we have finished our contraceptives. Thank you.